Okay, gang, so let's finish up this video on ARDS, acute respiratory distress syndrome. We just finished talking about pathophysiologic changes and what's happening on a cellular level in video 1, and now we're going to talk about some clinical manifestations. So often, as mentioned in didactic last night, one of the first things that you see is that a patient will have altered mental status. So the same is true here. You might see the patient begin with altered mental status and anxiety, shortness of breath, tachypnea, the increased rate of breathing, and lung changes, starting to hear some crackles or rhonchi, intercostal retractions, use of accessory muscles, and then cyanosis. So what does this mean for you as the nurse? Again, let's go back to identifying your patient's risk factors and doing baseline assessments. So you are going to have a patient in your sim this Friday that has pneumonia. If we go back to our slide for risk factors, we'll see that one of the second things on there is diffuse, meaning kind of everywhere. Pneumonia is a risk factor. So this patient's got an existing infection. If you look at her temperature, we know that she's running a fever. And so we should probably think about just making sure she's not septic if we haven't already taken some blood cultures. Let's get those going. The next thing is to pay attention really closely to make sure that we monitor for signs and symptoms of septic shock first and foremost. But the other thing is we know that this patient has a really high risk for developing ARDS. So what are we going to do? We're going to note that, do some really good baseline assessments to make sure that we can see if the patient does start to change. So look for altered mental status, changes in breathing, and changes in our lung sounds, okay? So these are all things that we can observe with the exception of actually checking the pulse oximetry. Otherwise, use your eyes, use your ears, and gather data. So I really like this cute little illustration of symptoms of hypoxia. You're going to see you got a little rat in bed there. So our early signs that we're going to see are patients restless, anxious, confused, maybe combative. We're going to see maybe an increased heart rate and increased rate of breathing. Remember that what's going to happen is there's going to be decreased oxygen delivery, so to the blood, and there's going to be a buildup of CO2 because we don't have gas exchange happening. We're going to have respiratory alkalosis, and we're going to increase our rate of breathing and our heart rate in an attempt to blow off that CO2. So we're going to start with that, and then we're going to get later on, we're going to end up with bradycardia as the heart rate kind of gives up here on trying that, and then extreme restlessness because our brain's going crazy without oxygen, dyspnea, which is severe. So in pediatrics, just an FYI, don't necessarily need to know this, but other ways that they manifest this, you can't really tell restlessness too much in an infant or anxiety. So some of the things you're going to see are they're not going to want to feed because they can't breathe, inspiratory stridor, you'll hear that wheeze, nasal flaring. Remember we talked yesterday about that natural deep breath that we take every so often? Take that deep breath. If you use your nose, did you notice that your nares flared when you did that? And that's our body's trying to compensate. Take in a nice deep breath. Grunting, trying to blow off that CO2, and then those sternal retractions, which we also can see in adults. So how do we diagnose this? I wish I could say that there was one quick diagnosis and bam, kind of like diagnosing sepsis. Let's do blood cultures. Bam, you got them. Bam, you're septic. This isn't the case here. We can't necessarily see inside these alveoli, but what we can do is we can note something. We can note refractory hypoxemia. Remember we said that we're giving oxygen, but we're not going to see any changes. So our pulse ox is going to remain the same no matter how much we turn up that oxygen, or it's going to decrease no matter how much we turn up that oxygen. So we've suspected this. We see the symptoms going on. What do we actually do? How do we translate this information into the bedside? So you need to call the physician, letting him or her know what are your changes that you've seen. So you call them and you let them know, hey, I'm taking care of this person, and this morning when I came in, this is what she was. Now this is what she is. I'm pretty sure we have worsening of the condition. I'm worried about ARDS, acute respiratory distress syndrome. Can we get some orders? And you would anticipate orders for one, a chest x-ray, ABGs, and possible transfer to the ICU and or prepare for intubation, depending on how bad our refractory hypoxemia is and how fast the patient is going downhill. So the chest x-ray is taken stat, and those ABGs are drawn stat, and this is what we can expect. We can expect to see on those ABGs, if it's happening initially, we can expect to see respiratory alkalosis and eventually respiratory acidosis, again, as we try to blow off all that CO2. So anticipate changes in your ABGs, anticipate that your blood oxygen level or your arterial oxygen level is going to be very low, and then our chest x-ray is going to be whited out because our lungs are just full of crap, full of fluid. It's all swollen, and we see the entire lung is whited out. So what are we going to do? First of all, if you're working on med-surg, we're probably going to transfer the patient to ICU, and they're probably going to get ventilated, like, if we can get them there. The other thing that we're going to do in the ICU is we're going to, one, put them on the ventilator. We're going to make sure that we're trying to correct the underlying disorder. So in the case of our patient for Friday, if she goes into septic shock secondary to pneumonia, we're going to get those cultures back, hopefully have culture insensitivity on the sputum, and we can begin to treat her pneumonia. And the faster we treat that pneumonia and the faster we provide cardiopulmonary support via a ventilator, the better the patient's chances of survival are. So there are medications, but they're just really the medications that we're going to give, again, are going to be targeted at the underlying disorder and keeping the patient comfortable on the ventilator. So we want to make sure, one of the key things I want you to remember about this is that we're going to make sure that we don't, because remember, again, there's a problem with the alveoli. So we can put oxygen and blow oxygen into the lungs as hard as we want to, but as long as there's a problem with the alveoli, we are not going to be able to get oxygen to gas exchange to happen. So we just want to give them oxygen support. The important thing with a ventilator is that it's going to be forcing their lungs to continue to open and contract here and keep them basically alive even though their lungs are in shock. And then we're going to want to add PEEP. We're going to make sure that we have that end pressure. So normally, again, we have that surfactant that's keeping our lungs open at the end of expiration and keeping them from collapsing during expiration. But without that surfactant on the ventilator, we're going to make sure that we add a little bit of PEEP there to make sure that we're manually keeping those alveoli, that the ones that don't have surfactant, remember that's neighboring ones or the brother-sister ones to the ones that are flooded, to keep them from collapsing, we're going to add that positive end pressure there. So another thing that we can do is position the patient in a prone position. And so what this does is it basically improves ventilation when we change the pleural pressure, and it can help with atelectasis. So remember, atelectasis is the collapse of those alveoli, most likely the alveoli that were collapsed due to a lack of surfactant. So when we flip them on their stomachs, it creates pressure changes, it decreases the pleural pressure, and if we have a decrease in resistance, then we can have a little bit more ventilation there. So that's what that's all about. So we know that this is effective overall when we see, and this is just about ventilation, so we're going to keep an eye on our ABGs and make sure our blood oxygen levels are improving. And then with the, as far as the pulmonary edema, we're going to monitor, again, our ABGs and our chest x-ray and the underlying condition. So after the diagnosis, again, we're going to make sure that there's PEEP on there, and that is to keep the alveoli from collapsing during exhalation. We're going to keep an eye, because PEEP can cause a decrease in the cardiac output because it decreases venous return. We're going to want to really keep a close eye on that urine output to make sure that we don't have a decrease in cardiac output. Keep an eye on their LOC, especially if you have them partially sedated. They might require hemodynamic monitoring. And the thing that's going to tell us, this is really important for you to know, the thing that tells us whether we're dealing with pulmonary edema because of ARDS or pulmonary edema that's heart failure related is our partial wedge pressure. Okay, that's what's going to tell us. Because remember that in heart failure, there's going to be an increase in wedge pressure with the pulmonary edema. With ARDS, we're going to see an increase, or we're going to see a normal wedge pressure, but with pulmonary edema. So again, normal wedge pressure with our PAWP, or with our ARDS. Before the diagnosis, again, we've got to identify those risk factors. We've got to do our baseline assessments. Patient's restless, we've taken some vital signs, maybe we see an increased respiratory rate, tachypnea, we see dyspnea, and we see tachycardia. Get an O2 sat. Listen to the lungs. Is the O2 sat low? Try oxygen. Is it improving? Do we have refractory hypoxemia? And do we hear fluid in the lungs? Are we hearing crackles, rhonchi, or nothing all of a sudden, whereas earlier we heard something? We've got a problem. We need to act quickly. We've got to call. We've got to anticipate interventions, our ABGs, chest x-ray, and possible intubation. The rest of these slides are about weaning from the ventilator and extubation, but these are just FYI. We're going to skip over that and go ahead and end this on ARDS. The last thing that I want you to do is please remember that all of these are about two primary nursing diagnoses: impaired gas exchange and ineffective airway clearance. That relates more to the ineffective airway clearance, is more specific to cystic fibrosis. So take a look at those nursing diagnoses. And actually, I would encourage you to use ACLY, your nursing diagnosis handbook. Go to the little green part and look up some of these nursing diagnoses. You can go to ARDS. It'll take you over to acute respiratory distress, and you can see that one of the first things on there is going to be impaired gas exchange. Same with cystic fibrosis. You can look that up and take a look at some of the nursing diagnoses that are common with cystic fibrosis. I'm looking that up right now so I can tell you. Cystic fibrosis. There we go. We've got activity intolerance, ineffective airway clearance, anxiety, body image, impaired gas exchange, all of those on there, and impaired nutrition. So for all of them, impaired gas exchange is your priority. For cystic fibrosis, you have ineffective airway clearance, and the other big one with cystic fibrosis is your imbalanced nutrition. So take a look at those. If you want to know, hey, what should I do? Look at those primary nursing diagnoses, and those are going to give you some ideas about nursing diagnosis, nursing treatment, and what we're going to do. So, and you can relate those back to our nursing interventions and treatments, okay? So hopefully this helps. Let me know if you have any questions.